And with that, I'd like to introduce our first keynote speaker, which is Dr. Katrina Tatton-Brown. There has actually been an error in the printed program, or there might be. Dr. Tatton-Brown's talk is titled The Evolving TBRS Phenotype. Dr. Tatton-Brown is a medical genetics doctor working in London, UK. She studied medicine at the University of Oxford before training in pediatrics and then in medical genetics. She has been investigating conditions associated with increased growth and a learning disability since 2001 and has published widely in this area. She also holds a specialist growth clinic at St. George's Hospital in London, where she meets patients and their families from around the world. Kate, as a part of a team of scientists and clinicians, first discovered DNMT3A gene alterations as a cause of an overgrowth intellectual disability syndrome in 2014. Since this time, she has been working to delineate the clinical associations of this overgrowth disorder and to develop evidence-based management guidelines. Some of this work has already been published, but work is also ongoing and being undertaken in close collaboration with the TBRS family group. Please join me in welcoming Dr. Tatton-Brown to the stage.
So thank you very much, Kit, and thank you very much for inviting me to come and speak today. I have to say I'm so pleased to be here. Everyone who knows about my journey, it's been a momentous journey, so I couldn't actually believe 10 hours ago that I'd be standing here and made on the stage. So it's a great, great joy and a great relief to be here with you all. So thank you also for that very kind introduction. As Kit said, my name's Katrina Tatton-Brown, and I describe myself as a clinical academic. So I hold a clinical practice and I hold NHS clinics, but I also research overgrowth intellectual disability syndromes. So I'm going to talk today about our journey, really, from the discovery of DNMT3A causing overgrowth and then really through to now and thinking about digging into and mining that registry data. So I'm going to spend the first bit just talking about researching TBRS. Before then, I then focus very much on the phenotypes, and then thinking about how our knowledge of that phenotype is evolving. I'm going to touch briefly on some preliminary genotype-phenotype associations that we've been doing, and then I'll wrap up by thinking about some management guidelines. But I'd like to start just by thinking about this virtuous wheel. And this is really, I hope, summarizing what we're all doing in this room today. And I think we all work together to grow our understanding of TBRS. It goes from DNMT3A gene discovery through to understanding all about the different mutations, the different variants that cause TBRS, to then understanding what DNMT3A does and why disruption of DNMT3A should result in the overgrowth intellectual disability phenotype. And then thinking about the phenotype, but that in turn plays into the basic science research. So it's so critical that we all work together and learn from each other's research. But today I'm going to focus on that top upper quadrant, thinking about the TBRS phenotype. This is a time scale of my journey with TBRS, starting in 2014, where we first identified DNMT3A, through to now. And I'm going to sort of dig into different elements of that timeline in this talk today. So first of all, if we start at the inception, so 2014, when we first identified DNMT3A. I'm sure most of you are aware that this started really with the advent of whole exome sequencing. Back in 2014, we were super excited about this new technology that was suddenly available to us. That's now, of course, been superseded by many different layers of advances beyond that. But we had whole exome sequencing available to us at the Institute of Cancer Research, where I was working. And initially, we cohorted some children who had been recruited to the Childhood Overgrowth Study, which is the study that I ran. And we were looking to see whether those children who had very similar clinical characteristics might have variants in the same gene. And indeed, we identified 2 of those individuals had variants within a gene called DNMT3A. So having identified those variants, we then extended our analyses to 456 individuals and identified a further 11 patients with alterations in DNMT3A, bringing our total to 13. We then published that finding, and this is a table from that publication. And you'll see from that publication that the majority of individuals had missense variants, that all had an intellectual disability, and that this was most frequently in the moderate range, and that all bar one had overgrowth. And we defined overgrowth, and we continue to define overgrowth, as height and or head circumference at least 2 standard deviations above the mean. So by applying that criterion, the majority of individuals were also overgrown. We didn't really see signals for additional clinical features other than 4 individuals who had kyphosis or scoliosis. So we thought that that was probably a likely association. And all the individuals within that first cohort shared similar facial characteristics. So the facial shape was round with heavy horizontal eyebrows, narrow palpable fissures, and strikingly, those children who had secondary dentition, the front central incisors were usually on the larger size. So let's return now to this timeline. So we then went out across the world and did a call to see whether there were other children, other adults, who had been identified as having DNMT3A variants and a diagnosis of TBRS. And through that call and working very closely with family organisations, we identified 55 patients who had a diagnosis of TBRS. So this enabled us really to start defining the phenotype much more accurately than when you're restricted to just 13 patients. And through that extended study, we were able to see that kyphoscoliosis was indeed an association of TBRS. Hypermobility was very common. And for the first time, we started thinking that actually obesity was one of the associations of TBRS as well. And we hadn't seen that in the first 13. So we started thinking that as well as TBRS being an overgrowth intellectual disability syndrome, this was a condition where we also include obesity in those anthropometric measurements. This led to us looking at that in more detail, and we, in 2022, undertook what we call the obesity study. And this was undertaken with my colleague, Sana Ulsters, and we have a poster over there somewhere. And we did an online survey, again with the support of the TBRS community. This was an anonymized MS form survey, and 74 people registered and included themselves in this study. And we really asked lots of different questions about weight, about the age, about onset of weight gain, and then started thinking a little bit about eating behavior. And we used the Daikin score for that, which is a validated method that was established in Prader-Willi syndrome, but is a well-known method to really look at the different sorts of eating behavior. Now, all of that is detailed on the poster, so I'm not going to go into that in great detail now. Essentially, we showed that 65% of individuals were either overweight or obese. The onset of the increase in weight was usually less than 5 years of age, and that was in contrast to what we thought was happening, because we thought it was actually in early teenage years. But actually, through the survey, we were able to show that it was actually happening at a much earlier age. And where a child was, or an adult was overweight or obese, families were reporting that actually their behaviour was very much in accordance with that hyperphagic behaviour. So really difficulty in reducing the amount that that individual was eating. Now, at a similar time, Harrison's and Peggy's group were looking at mouse models of TBRS, and they were also able to show that the mice with TBRS would also have increased weight. But interestingly, and we'll hear from Harrison and Peggy later, interestingly, the mice weren't showing hyperphagic behaviour. They weren't really demonstrating food-seeking behaviour. But it was more to do with the adipocytes and the size of the adipocytes, and I think you might be talking about that later. So whether in humans and the TBRS is a combination of both how that fat is being metabolized, the adipocytes are developing, and also some hyperphagic behavior. It's probably all of those, and we need to keep exploring that. So back now to our timescale. So you'll see that in 2022, I really started looking at some of the registry data, and I did report back last year the first 62 patients. So today, I'm going to tell you about 92 individuals from the registry now, which has really started to push forward our understanding of the TBRS phenotype. So as I'm sure you're all aware, the registry was developed in collaboration with NORD and is very much a TBRS community initiative. It is funded, developed and managed by the community, and it is the families who enter and manage their data. And that's in contrast to how we've really collated phenotypic data previously, when we've been reliant upon clinicians engaging and completing questionnaires. And the registry is available to the scientific and clinical community on application, and those applications are reviewed and approved by the Medical Advisory Committee. So the data that I will present today is collected from a 23-month period between September 21 and August 23, and it includes both single entry data and also where patients and families have gone in and updated their information. So this was work that was very much facilitated by Kit. Thank you very much, Kit, for all the work that you did on this and really cleaning up those spreadsheets. So by the time I received 19 different spreadsheets, each with about 40 columns, it was in a very user-friendly version. So thank you very much. And thank you also to those families here who have inputted their data into this registry. And then over to Eric now, because Eric then went through those variants, really applying his scientific knowledge and his ACMG framework to look at the DNMT3A variants, to really ensure there was some consistency as to how we are classifying them, and also looking at those variants that were classified as of uncertain significance, to make sure that they were of uncertain significance still, or whether they would be better classified as likely pathogenic or pathogenic. And then finally, we undertook some genotype-phenotype associations. And this was done in collaboration with my colleague, who is an extraordinary statistician, Dr. Rena Christer at St. George's. And we looked at mutation type versus growth, intellectual disability, and then a range of different associated clinical features. So I'm going to present the results of this now. So we had 111 completed registries, but there were a number of participants who didn't complete enough of the data in order to be able to include their entry. So we had to exclude 7 individuals where there weren't enough variant details, there weren't enough clinical data, which brought us to 104. And then a further 12 individuals were excluded because they had DNMT3A variants of uncertain significance. Now, it may be that in time those variants are reclassified as likely pathogenic or pathogenic, but where we're trying to really pull together a robust understanding of phenotype, it's really important that we tether that to robust classification. So for the purpose of this, we've restricted it to likely pathogenic or pathogenic DNMT3A variants. Amazingly, the participants were exactly 50-50, male and female, and the age range was 0.7 years up to 43.3 years was our oldest participant. And there were a range of different DNMT3A mutations or variants. the missense variants still remain the predominant variant type, which is really interesting to me, where we're thinking that this is a loss of function phenotype, and we do see 9 patients with whole gene deletions. Frameshift variants were identified in 15, and then splice variants 10. Now, there were a number of missense variants that were identified in more than one individual, and then we had 4 mosaic cases, and these were somatic mosaic cases. This is a cartoon of those different variants with missense variants at the top and then frameshift variants at the bottom. And there were 11 different variants that occurred in more than one individual. And as you see, the hotspot variant that we're all now very familiar with at ARG882 remains the commonest mutation type that we're seeing. So a range of different clinical features were identified, and this is a cartoon, a figure that was pulled together by my very talented colleague Lily Barnett, with whom I do a lot of educational work actually. So she's pulled this together, and I think is a good way of trying to illustrate the different clinical features that are associated with TBRS. Now, I'm going to dig into each one of those areas that are shown in the boxes. So I won't now talk about those. I'm going to talk about the other features on this list. So brain MRI findings were identified in 13%, and these were most commonly ventricular megaly and Chiari malformations. Glasses were over half of the individuals who participated in the registry wore glasses, most frequently to read rather than short-sightedness. And teeth were a significant issue. Now, dental crowding hadn't really been on my radar as something that was reported very frequently, but 64% of individuals were reported to have dental crowding. We know about large frontal incisors, with 64% of individuals reporting that. And then 11% reported that the baby teeth were slow to be lost. Renal anomalies are rare, and they're reported in only about 5%. And both umbilical herniae and constipation are relatively common. Nearly 2/3 of individuals had hypertonia, and this was most commonly reported in the neonatal period and tended to resolve as individuals got older. About 1/3 of individuals had recurrent ear infections, and this often led to glue ear, and a lot of individuals had grommets as well. And there were 21% of individuals who reported having hearing loss. What wasn't clear from the registry was whether that hearing loss was conductive hearing loss and was related to the glue ear or not. That the data wasn't there to be able to tease that out. And then hypermobility was reported in over 80% of individuals, and hirsutism was common, and this particularly affected the back and the legs and was reported in nearly half of the participants. And this is a heat map that's pulled together, really just showing that data where we have the participants along the top and then all those features down the left in decreasing frequency. So as promised, I'm going to dig into those features that were shown in the red boxes. And I'm going to start first of all with growth. So 91% of individuals would have met our criterion for overgrowth. So just reminding you, that is either head and height, at least 2 standard deviations above the mean, or both together. So 60% of individuals had tall stature, and 69% had macrocephaly. And you'll see on these graphs here that the red dotted line equates to 2 standard deviations above the mean. The naught is the mean. So even where an individual wasn't tall or had a bigger head circumference, pretty much everyone was still taller than the mean. There are a few outliers there. And in this study, 50% of individuals had a weight that was 2 standard deviations or above. So moving on now to learning. Where an individual's learning and development was included in the registry, all were said to have a learning disability. There were 31% of the participants where not enough data was provided to classify that learning as mild, moderate, or severe. And so there were some developmental milestones included, and there was a question that asked for that classification to be made, but there just wasn't enough to be able to robustly classify. So we did have 31% where the child was said to have a learning disability, but the classification was not possible. Now, for some of those individuals, they were probably just too young to make that shout. And again, a moderate intellectual disability is the most common category of learning disability. For 28 individuals, we did have information on IQ scores. And this graph shows where that IQ score for that individual, whether that individual was classified as having a mild, moderate, or severe learning disability. And what this graph shows me is that classification isn't completely robust. An IQ score is an objective measure, as objective as we can get, of classifying an individual's learning. And the designation as mild, moderate, and severe is very much more a subjective score. And you'll see there's quite an overlap there between the moderate and the severe. Moving now to behavioural and psychiatric issues. So 42% of individuals reported as having a behavioural issue and 21% psychiatric issues. Now, it's a bit of a moot point whether these two should be separated out. And for instance, anxiety, should that be sitting under psychiatric issues or should that be sitting under behavioural issues? Where we're thinking about behavioural issue, by far the most common behavioural issue that's reported was autistic spectrum disorder. And then psychiatric issues, anxiety. But there are some children and adults who have combinations of those features. When we started our journey to understanding about TBRS, I did hear a few families reporting that their children had developed frank psychiatric issues like schizophrenia, like psychosis, like bipolar disorder, and there were a few individuals who were diagnosed with that, but not as many as I had feared or thought at the beginning of that journey. But cardiovascular issues are far more common than we had initially thought. Nearly 50% of individuals with TBRS are reported to have some problem predominantly with their heart, and atrial septal defect is by far the most frequent. And mitral valve prolapse or regurgitation is the next most frequent. And then you can see the other cardiac features that were reported through the registry. And I pulled this together because this is really important when we're thinking about surveillance and management and the ages at which we undertake this. So this won't come as a surprise to anyone. Right at the bottom, hiding down there with the axis, is PDA, and not surprising that that is identified at birth. The septal defects, again, unsurprisingly, tend to be diagnosed in early childhood. Valvular problems as a range through to early adulthood. And then the conduction and rhythm disturbances really can occur at any age. So we need to be aware there is that spread of when they might be identified. Nearly a third of individuals were reported to have a kyphoscoliosis, and for 25 of those individuals, age was provided for the onset of the kyphoscoliosis. And again, this is important for thinking about surveillance. So the youngest age of diagnosis was 1 and the oldest was 36 years. And this is a graph showing ages where you can see participants along the bottom and then we've got the ages up the side. And so you can see that the majority of individuals were diagnosed with kyphoscoliosis in childhood, so at younger ages than 15. So it's less likely to happen in adulthood, although we have fewer adults in the registry. So we need to keep looking at that and following up that data. 23% had afebrile seizures, and it's important to stress that this is afebrile. So there were a number of individuals in the registry who were included with febrile seizures. And this data comes from 2 sources, and I was slightly anxious about this because there were quite a few individuals who had ticked no to seizures, but then when I looked at the treatment spreadsheet, then they were on anti-epileptic medication. So I was doing a little bit of cross-referencing between the spreadsheets. So these data come from that combined spreadsheet analysis using both the treatments and whether or not that box had been ticked. The most frequent seizure type was focal seizures, and then you can see the range of other type of seizures, but there were quite a few where the type of seizure wasn't indicated. And the age of diagnosis was available for 31 of the individuals, and all of them were diagnosed at less than 10 years of age, other than one individual who was diagnosed with temporal lobe epilepsy at the age of 40 years. And then finally thinking about cancers and tumours. And the registry is still a small data set. And this is the question that is so important to all of us. What is the incidence of cancer in TBRS? So again, by cross-referencing different spreadsheets, because actually not all of these individuals had ticked yes in the box in the oncology spreadsheet, I was able to see that 8 individuals were reported as having been diagnosed with a cancer or a tumour. And this was the range of different sorts of cancers that were diagnosed, the age at which they were diagnosed, and the different DNMT3A variants that they had. So we often talk about AML, and we think about the association of AML and TBRS because we know that somatic DNMT3A variants are one of the drivers to the development of AML, and we'll hear a lot about that today, I'm sure. 2 of the individuals who participated in the registry had indeed been diagnosed with AML, one at the age of 12 and one at the age of 19. One of those individuals had the ARG882 cis mutation, which we know is the hotspot mutation in TBRS, but also the hotspot mutation in AML as well. One individual had a neuroblastoma, one a glioma, one had a cutaneous T-cell lymphoma, one both a dermatofibrosarcoma protuberans and melanoma. An individual had breast cancer diagnosed at the age of 40, and then one individual I found from a different spreadsheet had an ovarian tumour, but I didn't have more details on that. So you can see there's a range of different cancer types there at different ages, and it's just really important that we continue to collect these data and know whether the other non-AML cancer types are associations of TBRS or whether that is just a coincidental occurrence. So we just need more data to try to tease that out. And I thought it would be helpful to put that in the context of the published reports. I haven't combined the two because I suspect that many of the individuals who participated in the registry would also have been published previously. So we'll then overinflate the numbers if the 2 data sets are combined. But you'll see from the published literature, AML is indeed the predominant tumour type, and those are the different reports down that first column. the different DNMT3A variant types, and the number of cases that have been reported. ALL has also been reported along with lymphoma, neuroblastoma, and glioma. And that individual on the right, shaded in blue, is an individual who had developed a neuroblastoma and then had gone on to develop a lymphoma later on, so that is the same individual. So I did promise a year ago that when we had larger numbers of participants, so a larger data set, we would start to undertake some genotype-phenotype associations. So really drilling down to see whether the type of DNMT3A variant, so whether the variant is missense, whether it's a loss of function, or whether it's a whole gene deletion, whether that influences the severity of learning, the growth trajectory, or those other clinical associations that an individual might have. So we looked at those 3 variant types in association with intellectual disability, overgrowth, and a number of different clinical features. And I'm not going to walk through these. There's 2 tables on this slide and the next, but it's to show you that really nothing came to light. There were no robust associations at this moment in time on this current data set. The only one was hypermobility, where individuals with a loss of function variant might be more likely to have hypermobility, but that is not robust, and there's nothing really that can be taken from that at the moment. And really, our data set remains too small. We need far, far greater numbers of individuals to start trying to tease out these associations. But if we can, down the line, that will be really important information for families, because that may influence our surveillance strategies that we employ. Which brings me to the last bit of my talk, which is thinking about those surveillance strategies and the management of individuals with TBRS. And I think about this in 2 categories, and many of you will have seen this slide before and these guidelines before. And what we're doing is just iterating, we're building on this as we learn more and more about the TBRS phenotype. So when we're thinking about management, it's helpful, I think, to think about it in 2 different strategies. First of all, baseline investigations at the initial presentation, and then ongoing surveillance. And you'll see that these guidelines are really picking up on all those various different clinical associations that we now know are part of the TBRS phenotype, and the age at which they are often diagnosed. So because of the cardiac issues, a baseline echocardiogram is pretty imperative in TBRS, where we've got nearly 50% of individuals developing a cardiac issue. As hypermobility is so very common, early physiotherapy input is very helpful, and then baseline hearing and vision assessment. And then there should be regular follow-up, and the interval of that regular follow-up will really depend upon the issues that an individual has. But it'd be really important that the geneticist or the paediatrician or the adult physician who is reviewing family members should think about behavioural issues, those psychiatric issues, making sure that the back is monitored for the development of kyphoscoliosis, asking questions about afebrile seizures. We know that dental issues are a real issue in TBRS, so making sure that there's good dental surveillance. Sleep apnea can be an issue, so again, asking those questions, and then thinking about bowel problems, particularly constipation and hearing. And then there should be regular ongoing cardiac follow-up, including an ECG because of those rhythm disturbances. And then we need to think about obesity and the tendency to put on weight, and thinking about practical and lifestyle interventions, but also Jill and I have had conversations about pharmaceutical intervention potentially in the future. And then, of course, the big question, and it's a question we have to keep coming back to, we don't yet have the answer to, is what tumour screening should we be implementing? And should it be screening for AML? And what would that look like? What would the interval be? It's a really difficult question. And should it be broader than that as well? So I hope I've convinced you that we've made considerable progress in our understanding of the TBRS phenotype since our initial description in 2014. And I'm really looking forward to hearing everyone else's talks later today, because it isn't just the phenotypic progress. The progress in understanding DNMT3A has been so exciting, and I've loved reading all of your research about it and seeing that puzzle that I presented at the beginning really come together. We now really understanding about that range of different DNMT3A variant types. We know that missense variants are the most common. I say beware of mosaicism because it seems to be more frequent in TBRS than in other genetic conditions. And I'm always a little bit concerned because of clonal hematopoiesis when we're identifying mosaicism, particularly in an adult patient. So I always just flag to colleagues, beware where you're identifying mosaicism in DNMT3A. When we first described TBRS, we described that the cardinal features were intellectual disability, overgrowth, and characteristic facial appearance, and that remains. I think that triad remain the cardinal features. But we now know that a number of different clinical features are absolutely associated, and these include hypermobility, kyphoscoliosis, obesity, and cardiovascular disease. And so we've done some rudimentary genotype-phenotype association studies with no clear signals yet. It did not surprise me. The numbers remain too small. So we need to keep really encouraging people to participate in the registry, both to update their data so it is as robust as possible, but for new participants to be included as well. So on that note, thank you all very much for listening to me for the last half an hour or so, and for over the years listening to me. There's a whole load of people that I would like to say thank you to. I'm not going to read them all out, but I'm sure I haven't covered everyone. But really critically, thank you to all the families who have buoyed me up over nearly 10 years now, and it's just been so amazing working with you, and it's a great joy to be here with you for the next few days. And we need an updated photo, because this was 4 years ago, I think, now, so we need one from 2023. Thank you very much.